Welcome to AETCM, the Emergency Medicine channel. Today let us discuss about encephalitis. Encephalitis means inflammation of brain parenchyma. Meningitis means inflammation of covering of the brain. Most of the time, encephalitis is due to viral infection or other types of inflammation due to autoimmune disease, like that is immune mediated disease, paraneoplastic syndromes, malignancy induced encephalitis. Like that, encephalitis basically it is due to virus. Sometimes bacterial meningitis can lead to encephalomeningitis, and non-infectious conditions also can produce encephalitis. So meningitis and encephalitis, main difference is meningitis means inflammation of meninges, no inflammation of brain parenchyma. Encephalitis means inflammation of brain parenchyma, no inflammation of meninges. But sometimes you can get encephalomeningitis or meningoencephalitis. That means both the parts are involved there. So it is that encephalitis means suppurative inflammation of brain. Pus is formed inside the brain. Pus means it is not frank pus. It may be mostly the increased cells in the CSF. Now there are a lot of viruses can produce encephalitis. HSV1 can directly involve the brain and produce herpes simplex encephalitis, temporal lobe encephalitis. HSV2 also can produce encephalitis or meningitis. That is not due to direct inversion. It is only an immune mediated aseptic meningitis. Measles, mumps, polio. Polio is a chronic type of meningoencephalitis. Chronically it produces peripheral weakness. Japanese encephalitis, varicella zoster virus encephalitis, Epstein-Barr virus encephalitis. HIV encephalitis or HIV involvement of CNS is a chronic inflammation. It normally does not produce acute encephalitis, but the opportunistic infections in HIV can produce chronic meningitis and chronic encephalitis. Cytomegalovirus, another type of opportunistic type of inflammation which is commonly seen in HIV. Nipah virus, that is also very common in Asian countries. Recently in India also we had outbreak of Nipah virus. Now the clinical features are same like meningitis. Most of the features are resembling to meningitis except for the neck stiffness, fever, severe headache, altered sensorium. This altered sensorium is not there in meningitis. It's a feature of encephalitis. And raised ICP features also you can see, like headache, vomiting, papilledema, eye examination, hypertension, bradycardia. This is called as Cushing's reflex. Focal neurological deficits, like a patient can have weakness of one side. It is mostly due to the vasculitis part of the meningoencephalitis. Convulsions also can be seen in some patients. Now, herpes simplex encephalitis is one of the most common encephalitis which we see in our clinical practice. But that is a specific type of encephalitis. But many a times we don't get an answer for the encephalitis. We may not be able to diagnose what type of virus is producing encephalitis. But HSV1 normally we get an answer. We get in MRI findings. We get PCR in CSF. All these things are very, very important. These patients can have psychiatric manifestation, altered behavior, abnormal behavior pattern will be there, seizure will be there. So all these things point towards a temporal lobe type of encephalitis, epilepsy and altered behavior with encephalitis. It can also lead to olfactory, gustatory hallucination, anosmia, personality changes and memory disturbances. Neck stiffness is not usually a feature of encephalitis, but if the meninges also involved, then you can get neck stiffness. Parotid inflammation, that can be seen in mumps encephalitis. Hydrophobia, aerophobia, pharyngeal spasm, that all suggest rabies. And past history of rabid dog bite also going in favor of rabies. Vesicles in a dermatomal pattern, especially on the face, that indicates varicella zoster virus encephalitis. Herpes simplex virus encephalitis is one of the most common type of presentation of encephalitis, where you can make a diagnosis. We can see the patient and we can make a diagnosis of herpes simplex, but majority of the encephalitis will not be able to make a diagnosis of the etiology of viral encephalitis. We will not be knowing what type of virus is involved there. But herpes simplex, there are some classical features, so we can easily diagnose it. It's a necrotizing temporal lobe involvement, that is an inflammation of temporal lobe with the temporal lobe epilepsy and altered behavior that leads to coma. That is a classical finding in HSV encephalitis. Both MRI and CSF can pick up HSV1 encephalitis. Bell's palsy can be there, cranial polyneuropathy can be there, transverse myelitis can be there, Guillain-Barré syndrome can be there. The diagnosis, MRI shows temporal lobe lesion and CSF shows HSV1 PCR positivity. Japanese encephalitis is very common in endemic areas. Not in all areas you get Japanese encephalitis. Specific pockets in our country, they can have this Japanese B encephalitis. It's a flavivirus. It's transmitted through Culex mosquito. Reservoirs are mainly pigs. Most of the time the pigs are the reservoirs. Other animals and other birds also can be reservoirs. The clinical features are same like any other viral infection. They can have high degree fever, malaise, anorexia, vomiting, photophobia, headache, brainstem encephalitis. That means brainstem encephalitis means they can have cranial nerve involvement. Seizures can be there, multifocal CNS involvement, hyponatremia, that is mostly due to SIADH, that is due to salt removal through the kidneys, losing salt through the kidneys. Extrapyramidal manifestations also can be there in Japanese B encephalitis. Nipah virus is not very common in our country, but there are some outbreaks which occurred previously in our country, but it is not very common to get Nipah virus infection. Patient can have segmental myoclonus, hypertension, tachycardia, brainstem symptoms, cerebellar disorders. All these things also can be there. Other than these viruses, many patients like some bacterial infection like TB can have meningitis associated with, they can have encephalitis. Malaria is one important parasite which produces malarial involvement of the brain. It is called a cerebral malaria. That patients can have seizures, altered behavior, coma, all these things. So other than viruses, many other organisms like bacteria, parasites, patients who is having HIV infection, many other unknown viruses or opportunistic viruses can also produce encephalitis. Many viruses in HIV can produce progressive encephalitis, progressive multifocal leukoencephalopathy. Like that, so many other clinical presentations also there. I am not discussing all these things because they don't come under emergency medicine management. Herpes simplex encephalitis is one of the most easily diagnosable encephalitis, whereas whereas we can make it as viral encephalitis. Diagnose can be made as viral encephalitis, but to investigate and find out the cause is very difficult, and it will become very costly affair. And if there is a treatment option for that, we can investigate. But other than HSV1, there is there are a lot of other viruses which can produce encephalitis, and there is no treatment available for all these things. So many times we don't investigate for other viral infections, but HSV1 can be easily diagnosable and it can be easily treated. So you can see here MRI that shows at right temporal lobe enhancement in gadolinium MRI. So that is a classical picture of HSV1 encephalitis. HSV2 also can produce aseptic meningitis, but that doesn't have encephalitis or this type of classical picture. Now we have to do an LP. Whenever we are suspecting an infection in the brain, we have to do an LP. LP sterile, under sterile precautions, we have to do LP, and LP will give you fluid. Lumbar puncture will give CSF through that. We can take CSF. We can see the cell type, cell count, protein, sugar, and AFB smear, gram stain, cultures. All these things can be done by doing this LP. But try to do imaging before the LP, because if most of the encephalitis you can have some raised ICP that can be easily picked up by either ophthalmoscopy, you can get papilledema, or if facilities are available, we have to go for MRI with contrast, because we can see whether raised ICP is there, any midline shift is there, or coning is occurring. All these things you can make out. And meningitis can be seen as a contrast enhancement in the MRI. So MRI should be done before LP study. Now CSF study, normally CSF is clear. In viral infection also it is clear, but whereas in bacterial infection it will be cloudy. Opening pressure is increased in both encephalitis and meningitis. Proteins are always elevated in all types of inflammation. Proteins are elevated. Sugars are normally, it is normal in viral encephalitis, whereas in bacterial, TB, fungal, all these conditions, even in malaria, they utilize the sugar in CSF and they reduce the sugar, usually more than 50% of the blood value. Same time you have to see blood sugar and CSF sugar. Reduced values occasionally seen in HSV, mumps, and some enteroviruses. That is also very important, because some viral infections you can get low sugar, but normally viral encephalitis sugars are normally normal. Proteins are elevated. Cell counts are increased. They are mainly lymphocytes. So normally bacterial meningitis produces elevated cells. They are neutrophils, but partially treated bacterial meningitis, after some days the neutrophils can change to lymphocytes, whereas in viral infection mostly when we are doing an LP it will be lymphocytes. But in a very high level of infection, acute, hyperacute phase of encephalitis, if you do LP, sometimes you can get neutrophilic predominance, but that is not the classical picture. Classical picture is after 1 or 2 days only patient will be coming to hospital. When we are doing the LP, normally we get a elevated lymphocyte count, and lymphocyte counts are not very high. They are maybe 250 or 300, whereas in bacterial meningitis it will be very high, 1000, 5000, 10,000, like that it will be counts. Now CSF PCR can be done in almost all types of bacteria or virus. Nowadays PCR or gene mapping can be done in many viral and bacterial infection, but many of the time whatever virus we get, there is no treatment available, but these investigations are very, very costly. So we try to restrict this type of investigation only in HSV1, because HSV1 there is a definitive treatment available. So if you make a diagnosis of HSV1, then treatment is very easy. So HSV1 PCR can be done. Sensitivity is 98%, specificity is 94%. Now we can see here, you can see all these charts, but I am not telling all these things. Only viral infection I am telling. Viral encephalitis, cell types are predominantly lymphocytes. They are elevated in hundreds. Normally they are elevated in hundreds, but rare condition they can be very high. Otherwise normally they are in hundreds. Glucose, it is normal. Some infections like mumps encephalitis and all, it can be HSV, mumps encephalitis, it can be slightly low, but normally all viral encephalitis it is normal. Proteins are usually normal, and slight elevation is known in all types of inflammation, including viral encephalitis. Normally when we compare with the bacterial meningitis or TB meningitis or fungal meningitis, they are all, it is highly elevated, but here it is a small elevation. It may not be sometimes significant only. Gram stain, it is negative, because it is not a gram positive or gram negative bacteria, it is only virus. Instead of that, we can go for PCR testing, especially PCR for HSV1 should be done. Then there are a lot of other investigations available in CSF, like many viral encephalitis can be due to, like initial viral encephalitis pattern can be due to tuberculosis. So all suspected viral encephalitis, we also have to do gene expert. Gene expert will immediately give the report. Within 1 or 2 days we'll get the report. Some patients who is having non-inflammatory non-infectious encephalitis. We have to look for immune-mediated encephalitis. So autoimmune encephalitis can be suspected, and autoantibodies can be checked in this CSF VDRL. Look for any malarial parasite. All these things are important in this type of encephalitis. So some patients who is having viral encephalitis, sometimes you can see CSF will be completely normal. We can sometimes call it as aseptic meningitis. So the cells may be normal, proteins may be slightly elevated, but if you do LP after 1 or 2 days, you can see the cells are elevated. So a normal cell in CSF will not rule out encephalitis. You have to see the clinical picture always. And most of the time we know that the cells are lymphocytes in viral encephalitis, but rarely in acute and severe encephalitis you can get slight neutrophil predominance, but soon it will change to lymphocyte predominant cells. Now, other investigation in patients who is having encephalitis, we have to take an ABG, we have to see blood sugar, we have to compare with the sugar in CSF, urea creatinine, that is other types of encephalopathies. You have to rule out uremic encephalopathy, hepatic encephalopathy, hyponatremic encephalopathy, hypercalcemic encephalopathy, and some patients we may require EEG study, because many patients who are admitted to emergency room will be in altered behavior. Sometimes CSF may show encephalitis or meningitis. We will not be getting an answer for the altered behavior. If the patient is having viral encephalitis and CSF is completely normal, most of the time that MRI also will be normal. So EEG can be done in that type of patients. If the patient is having temporal lobe lesions, mostly they can have temporal lobe epilepsy. That easily can be picked up by EEG. So there are some indications for EEG, so that can be done. Japanese encephalitis can have IgM antibodies in CSF. That also can be done in endemic areas. When we are managing the encephalitis, we have to always take care of the airway, breathing, circulation in emergency room, because these patients can have altered behavior, low GCS, aspiration, so many abnormalities can be there. So airway, breathing is very important. Rarely some patients can have circulatory collapse, hypotension, shock and all. That has to be corrected. In raised ICP, you can either pick up by ophthalmoscopy, funduscopy, fundus papilledema can be there, or bradycardia, that is a sign of raised ICP. Seizure is a sign of raised ICP. Anisocoria is a sign of raised ICP. So in all these conditions, or MRI or CT itself will tell you that raised ICP is there or not. All these conditions we can give dexamethasone. Dexamethasone is a drug which can reduce the inflammation in the brain, and it can reduce the pressure in the brain. So that is one drug, but some books may not tell the indication for dexamethasone in this type of conditions, but we can use it. It will be beneficial for the patient. So dexamethasone can be there. According to textbooks, dexamethasone is indicated in patients who is having bacterial meningitis. Before giving antibiotic, we have to give dexamethasone. In tuberculosis, to prevent the adhesions, you can give dexamethasone. Otherwise, dexamethasone is not an indicated drug in viral encephalitis, but in clinical practice, many patients who receive dexamethasone in viral encephalitis, they recover very fast, but textbook says no for dexamethasone. Whatever it is, we use dexamethasone in patients who is having viral encephalitis. Acyclovir is another important drug that should be used in patients who is having suspected encephalitis. And once you make a diagnosis of herpes simplex 1 encephalitis, we have to continue this type of drugs. If it is not HSV1, then we can stop it. We have to be very careful. This drug has to be diluted properly, given properly, otherwise patient can develop renal failure. So acyclovir dose is 10 mg per kg 8th hourly for 2 to 3 weeks. So when the patient come to emergency room, we may not be knowing it's a viral encephalitis, so we have to give a cocktail type of therapy. We have to give acyclovir, we have to cover the meningitis with vancomycin with ceftriaxone, we have to cover malaria with artesunate, and we have to give thiamine also. Okay, these are the common cocktail treatment given in most of the emergency rooms. But if you know that it is viral encephalitis, only acyclovir should be given. That should be given 10 mg per kg body weight 8th hourly. And once you know that it is not HSV1, you can terminate the infusion. Okay, so that is a treatment of choice. Valcyclovir also can be given in patients who is having HSV1 encephalitis. Now, there are some vaccinations available for many viral infection, including Japanese encephalitis. You can give vaccination, but only in endemic areas. You can give for persons over 3 years of age. The recommended primary immunization series is 1 ml doses given at 0, 7 and 30 days. So that can be given to prevent Japanese encephalitis in endemic areas. Rabies also, we have pre-exposure and post-exposure prophylaxis. Post-exposure regime is 5 doses, 6 doses actually. 90 days is not written in many guidelines, but Oxford guideline 90 days dose is written. That's why I am telling 6 doses. Many guidelines says only 5 doses are enough. 0, 3, 7, 14, 30. That is a 5 dose regime, and Oxford regime says that you have to give a 90th day also. But most of the doses given in our country, it is 6 dose regime. Human rabies immunoglobulin also should be given in severe bite and proximal bites like face, neck or upper limbs. You have to give, and severe bite also you have to give human rabies immunoglobulin. 20 international units per kg should be given for this patient. So we have discussed about one of the important neurological emergency, that is encephalitis. We should not confuse encephalitis with meningitis. Both are different entity, but many patients who is having encephalitis can have some meningitis, and many patients who is having meningitis can have some encephalitis. What we should remember is encephalitis is mostly due to, an infectious encephalitis is mostly due to viral infection, and infectious meningitis is mostly due to bacterial infection. And whether it is encephalitis or meningitis, we have to do a contrast MRI. So contrast MRI will pick up meningitis and some encephalitis like HSV1 also. It will be very useful. Raised ICP can be easily picked up by an MRI. LP has to be done. Most of the viral infections, the cells are predominantly lymphocytes, proteins are slightly elevated, and PCR should be done in both HSV1 and Japanese encephalitis. The treatment options for other viral infections are limited, whereas in HSV1 we have acyclovir. It should be given as an infusion. Whenever we give it as an infusion, always check the creatinine every day, because sometimes this acyclovir can produce reversible renal failure. Thank you.